Hello, my name is Sharon Mann, and I am in the process of forming a collaborative team here at DRHA that manages the care of patients that are diagnosed with heart failure. Our program is called Cardiac Healthy Futures. So today I'm presenting information that includes evidence-based practice guidelines for the care of heart failure patients. By the conclusion of this presentation, the staff nurses of DRHA will understand the incidence and prevalence of congestive heart failure, along with its impact on individuals, the community, and healthcare. By the end of this presentation, the staff nurses of DRHA will understand the role that nurses have in coordinating care for CHF patients. That understanding will be validated by a pre- and post-assessment survey, an improved bedside practice that includes evidence-based practice guidelines. By the conclusion of this presentation, staff nurses of DRHA will have more information along with other resources concerning the care of CHF patients. That information will include an e-poster. This learning will be demonstrated via pre- and post-assessment survey. Congestive heart failure is defined as a chronic disease process in which the heart is not able to do its job of supplying blood to the organs of the body. What you may not know is that 5.7 million adults in the U.S. have heart failure. Heart failure costs the U.S. healthcare system $30.7 billion each year. But that monetary cost also comes with a cost of human life. 1/2 or 50% of people who develop heart failure will die within 5 years of that diagnosis. In 2009, 1 in 9 deaths included heart failure as a contributing cause. This map from the Centers for Disease Control illustrates the death rate of heart failure patients from 2011 to 2013. Every state in our country is impacted. With such an astounding prevalence, you can understand the importance of being able to better care for those affected. In the process, we can impact individuals, communities, and our nation. 2.6% of the U.S. population has heart failure. There's 650,000 new cases diagnosed every year. The incidence of heart failure does increase with age. There's a lifetime risk of 20% for men and women equally aged 40. From the ages of 65 to 69, that incidence is 20 people per 1,000. And then for the ages of 85 and older, that incidence increases to 80 cases per 1,000. In caring for this population, the American Heart Association states that identifying risk factors is crucial. Patients who are most at risk for developing heart failure include those who have poorly controlled hypertension, coronary artery disease, diabetes, metabolic syndrome, obesity, high cholesterol, and cardiomyopathy. Once diagnosed with heart failure, the American Heart Association recommends taking steps to prevent disease progression, and this includes controlling those modifiable risk factors. However, once a patient becomes hospitalized with a diagnosis of heart failure, the goal of care then becomes, again, continuing in the vein of preventing disease progression, but this time by controlling symptoms. So interventions here are going to include fluid management, controlling hypertension, and patient education. Now, at the foundation of all of these efforts should be a strong interdisciplinary collaboration that includes coordination of care. And this is very crucial for patients who are going to be managed effectively once they get home and, once they're discharged from the hospital. The American College of Cardiology Foundation and the American Heart Association have identified 4 stages of heart failure. These stages serve as a guide for health promotion, risk reduction, and treatment. In stage A, or the very first stage, this is a patient that's at high risk for the development of heart failure, but they have no structural disease or symptoms. So again, this is going to be a patient who has one of those risk factors that increase their chances for developing the disease. And that again would be a patient with uncontrolled hypertension, heart disease, diabetes, or obesity. The goal for a patient in this stage is to make those lifestyle changes that address and control those modifiable risk factors, and that in turn will prevent that person from developing heart failure. And those interventions include, of course, making lifestyle changes of diet and exercise. This is a patient who may be placed on an ACE inhibitor such as lisinopril or Lotensin. And they can be placed on an angiotensin 2 receptor blocker or an ARB such as losartan or Hyzar. Also, a statin such as simvastatin would be needed to control cholesterol. In the second stage of heart failure, or stage B, this is a patient that now has structural heart disease, but no active signs or symptoms of heart failure. And this may be a patient who's had a history of a previous MI, and maybe they have some mild left ventricular remodeling and a low ejection fraction. The goal for treating patients at this stage is to prevent further cardiac remodeling and further structural changes within the heart. So once again, we're speaking of preventing disease progression. This patient will be placed on drug therapy that includes an ACE inhibitor, an ARB, and a beta blocker such as metoprolol. In the third stage of heart failure, also known as stage C, this patient now has structural heart disease and has begun to exhibit some symptoms. So the goals for a patient in this stage is to control symptoms and to educate the patient to prevent hospitalizations and death. Medications will include diuretics such as furosemide or Bumex, ACE inhibitors, ARB therapy, beta blockers, and aldosterone antagonists, and digitalis therapy. In this stage, surgery such as revascularization or valve replacement may be indicated. The final stage, or stage D of heart failure, this is a patient that's now in refractory heart failure, and they exhibit signs and symptoms even at rest. The goal in this stage is to control symptoms, improve quality of life, reduce hospital admissions, and establish end-of-life goals. Treatment options for a patient in this stage include heart transplant, chronic inotropic therapy, left ventricular assist devices, palliative care, and hospice care. So in order to gain an even greater understanding of how heart failure impacts the entire body, let's discuss some pathophysiology. Okay, first of all, you see pictured a normal heart and a congestive heart, so you can see the changes that have occurred inside the heart. So the amount of blood that's pumped by the left ventricle per minute is cardiac output. Preload and afterload affect cardiac output. The degree that myocardial fibers are stretched just prior to contraction is known as preload. The more fibers are stretched, the more forcefully they will contract. Afterload is the degree of pressure in the aorta that must be overcome for blood to be ejected from the left ventricle. In heart failure, the myocardium becomes weak due to a disease process such as uncontrolled hypertension or heart disease. So then a weakened heart does not have the ability to eject all the blood that it receives, and this results in poor systolic filling. That causes an increase in workload on the heart, and the left ventricle begins to enlarge or hypertrophy. The heart attempts to compensate for the increased workload. As it does this, changes in the size, shape, and structure of the myocardial cells occur. This is known as cardiac remodeling. Myocytes become injured by the excessive workload and they start to die. The result is that inflexible fibrotic tissue fills the spaces between those dead cells. Because the left ventricle has limits to its ability to compensate, blood begins to back up into the lungs, and hence we have the congestive state. Because of the pathophysiology of that congestion, the symptoms that are associated typically coincide with the severity of disease progression. The patient will typically present to the ED with edema, specifically pitting edema of the extremities. More classic symptoms of an acute exacerbation include shortness of breath, dyspnea, cough, and jugular vein distension. The patient may also complain of weight gain or loss, poor appetite, and fatigue. There are key elements that will be important in the physical assessment of this patient once they present to the ED. The cardiac assessment will include auscultation. Typical findings here may include an S3 or S4 heart sound along with tachycardia. The patient may also have a high blood pressure, chest pain, systolic murmur, and cardiomegaly. The assessment of the respiratory system will include auscultation along with noting rate, depth, and frequency of respirations. Some typical findings here will include dyspnea, shortness of breath, orthopnea, and bibasilar crackles. In the assessment of the kidneys, patient may complain of oliguria, and this will be due to the proximal tubular reabsorption of sodium. Patients may also have signs of abdominal tenderness and/or hepatomegaly. And the liver becomes involved due to passive hepatic congestion. And this, of course, is going to indicate a worsened state of disease progression. While assessing the patient's general appearance, you may note lethargy, diaphoresis, edema, and peripheral cyanosis of the extremities. In addition to the physical exam, there are certain labs and diagnostic tests that will be important to obtain. These tests are further going to indicate the stage of heart failure that the patient is in. First of all, a basic metabolic panel. The basic metabolic panel will be looking at sodium level, and hyponatremia is indicative of advanced heart failure. An increased urea and creatinine level will indicate the level of renal dysfunction. Elevated liver function tests are indicative of liver congestion, and hyperglycemia would reveal diabetes. The cardiac troponin level is important because that test looks at the troponin level, which is specific to cardiac muscle. An elevated troponin level is found in myocytic injury. The BNP, or B-type natriuretic peptide level, is a benchmark test. And that's because this is a peptide that is generated by cardiomyocytes. So when there's myocardial stretch occurring within the heart, this test is going to be elevated. Obtaining a 12-lead EKG and chest x-ray are also important. The 12-lead EKG will reveal rhythm abnormalities and cardiac infarction or ischemia. The chest x-ray will reveal pulmonary congestion and cardiomegaly. Other diagnostic tests that are expected will include the echocardiogram, cardiac catheterization, and cardiac MRI. The echocardiogram can provide information regarding the ejection fraction and any valvular disease. The cardiac cath is going to reveal some important etiologies such as coronary artery involvement and valve disease. The cardiac MRI is going to provide information regarding the myocardial structures, and that's important in disease staging. For heart failure, the emphasis and the goal remains prevention. Once a patient is diagnosed, prevention of disease progression remains a primary goal. For a diagnosed patient, traditional medicine is necessary and it's not optional in order to prevent exacerbations and disease progression. Holistic therapies can, however, be used to complement that traditional medicine. But I will say here that there are limited studies and inconclusive findings in this area. Even so, I have some examples here. Some herbal supplements such as CoQ10 and hawthorn have been found to improve blood pressure. Acupuncture as a therapy has been found to increase exercise tolerance. And other examples that have been found to be helpful are mind-body therapy and spirituality. And these have been found to help patients to manage symptoms of depression. In spite of improvements in standardized care, morbidity and mortality for heart failure patients have remained unchanged for the past 10 years. Heart failure is currently the most frequent diagnosis for Medicare patients. As we forge forward in attempting to make an impact, our greatest hope remains in prevention and coordination of care. We believe the Cardiac Healthy Futures program of DRHA will be the answer to that hope and the answer to the future of heart failure. Thank you.